We are live now.
Good evening, all. I, Shreya from Torrent Pharma, welcome you all to today's program. Thank you for taking out time from your hectic schedules and joining us live today. Aging is inevitable, and today, this increased longevity adds burden of spinal disorders. Along with it come the complications of osteoporosis and osteoarthritis. Sedentary lifestyle, improper diet, improper postures further add fuel and bring about the challenges like obesity and muscle weakness. This all eventually takes a toll on our spine health. As these challenges arise, so do the new possibilities. And today, to understand the same, we have an expert panel with us who shall be sharing their wealth of experience. Before we begin the program, let us all welcome our esteemed moderators and panelists for the day. I welcome our moderators for the day, Dr. Muralidharan and Dr. Manish Kothari. Dr. Muralidharan is a senior consultant and spine surgeon from Apollo Hospitals, Chennai. Dr. Manish Kothari is a senior consultant and spine surgeon from Jaslok Hospital, Mumbai. We have with us our three eminent panelists, Dr. Hema, Dr. Rishi Khanna, and Dr. Prashant Baid. Dr. Hema is a consultant rheumatologist from the MIOT Hospitals, Chennai. Dr. Rishi Khanna is a senior consultant and spine surgeon practicing at Ganga Hospital, Coimbatore. Dr. Prashant Baid is a senior consultant and spine surgeon from Apollo Hospital, Kolkata. Today joining us, we also have the overseas faculty. Joining us today are Dr. Marcin and Dr. Rajesh. Dr. Marcin is a consultant spinal neurosurgeon at the Royal Orthopaedic Hospital, Birmingham, UK. Dr. Rajesh is also a consultant musculoskeletal radiologist practicing at Royal Orthopaedic Hospital, Birmingham, UK. Thank you so much, all of you, for joining us today, and a warm welcome to all our moderators, our panelists. I now hand over the session to Dr. Muralidharan to kindly take us further. Thank you.
Hi, good afternoon and good evening and good morning to everyone, wherever you are. We know that aging is inevitable, and so as the osteoporosis and degeneration associated with aging. So the burden that aging, the osteoporosis and the degeneration on the spine in an elderly population is challenge is growing, and it gives pain and it affects their quality of life. So there is a growing concern regarding care about the spinal issues in elderly patient, and it has got a lot of challenges. So this aging spine webinar series is thought out to give different sessions, and each session will comprehensively cover each condition, how do we manage, and what are the surgical challenges in managing the spinal disorders in elderly population. We kickstart the session with burden of osteoporosis on the spine, and specifically osteoporosis related vertebral compression fracture or vertebral fragility fracture, and different scenarios, and how do we deal with as a surgeon or as a clinician when faced with it. We have a expert panelist, and both internal and from overseas, and we hope that we will make it more interesting, and the delegates will take a lot of points from it. So we'll start with the first one. Shreya, can you share my...
Hello?
Yeah?
Yes, sir. Yeah.
How do I put it in the full mode? Yeah.
Yeah.
Sorry. So that's not the one I wanted to bring in. Yes, that's the one. So we'll start with the case. It's a purely case-based interactive session. We'll start with the first case, the typical elderly patient, 74-year-old. She lives alone. She is mobilizing normally without any aid, with a background of type 2 diabetes and essential hypertension. She has no known history of any malignancy or anything, and she comes to emergency following a fall. She slipped and fell in the bathroom, and she has axial back pain, and she has some tenderness in the thoracolumbar region. So she is present with the plain X-ray, initial X-ray, and this is how this sometimes we get it because of the pain and the position they are in, and they are very frail. Sometimes you may not be able to get adequate view you needed. So looking at heart, you can see something is going at T12. So something is going at
But you're not audible.
Yeah. So Murli.
Yeah.
Yeah. Quick question to you. Patient with.
Can you hear me?
Yeah. Quick question to you. Patient with
Yeah.
fall, and you get a call from the patient. He's fall and she's got a back pain. What do you do next? Do you call the patient immediately for evaluation, or do you wait for some time, give them some analgesic safe like paracetamol or something, and ask them to come after a few days? What's your protocol? What do you do?
So, protocol is to do a clinical assessment. So I would want the patient to be present to the emergency or to your OPD, whatever way, but need to be assessed whether cause of the fall, because in an elderly patient it could be a mechanical or it could be a collapse. So we need to find out what is the exact cause for it. And then we need to find whether there is any associated injuries. Is that a pure one back pain, or she has got any other injuries? So I would want to see her, evaluate, and then give further recommendation rather than giving any recommendation over the phone. So this is the X-ray. So I just want to ask, so what the Rishi, see, if somebody presents to your unit with this fall and they've done a plain X-ray, and what would, this is the X-ray, so how would you proceed next? You're given some analgesia, and how would you proceed next?
Right. So basically, we are not able to visualize the margins of the vertebra very clearly in this graph.
Yeah.
And there's a lot of bowel shadows, especially in the AP view, which is completely confounding what we're able to do with the bones. So I will do a clinical examination, and basically we are not seeing anything grossly unstable here. And if her neurology is fine, then I will assume that she has some osteoporotic injury to the spine, and then give a trial of analgesics, bed rest, and then a lumbosacral brace for her to mobilize, and then reassess her again after a week with the proper radiographs again.
So you will give analgesia and reassess after a week.
Yep.
You would not take any further imaging at that stage?
At this stage, I don't think so, because if your neurology is intact and if I am able to see all the bones in alignment, then I am not unduly worried about having an unstable injury.
Okay. Prashant, what would you do in your institute?
I think I will redo the X-ray because it's grossly, for my standard, this is not a good X-ray. I'll redo the X-ray as possible.
The issue is the radiographer is saying, sir, this is the best we can get because she's lying and it's difficult to twist her and she's screaming.
If he or she has portion and it's much fracture, then yeah, I mean, I will give an analgesic. Probably give him a calcitonin nasal spray, and maybe for rest for 1 or 2 days and see the VAS score, how is it getting better or worse. Definitely examine the neurology. I'm sure the neurology must be intact. And they'll ask the patient to come back again after 7 days.
After 7 days.
Yeah.
So you would go with the Rishi's protocol. What about Marcin? Marcin, are you there?
I think his
It's still
Is it
setting up,
there?
I think. Yeah.
Okay.
Not there.
Manish, what do you do?
Yeah, I agree with Dr. Rishi and Prashad both, as in
Mm.
there's no need to investigate further if this is the best X-ray, and clinically they have a very classical fracture pain. I'm sure everybody
Mm.
has looked at it. They have difficulty changing position.
Mm.
Once they're lying down, they are
Mm.
very much comfortable. But once
Mm.
you ask them to turn on the bed or even try to sit up, they will always have they will need a lot of support just to sit up. Once they sit up or sometimes even stand, they feel like partly better, not fully better, but partly better.
Okay.
That's very classical of a fresh fracture. So if that's the presentation, then you give very safe, simple analgesia. Also, I will also just send CBC, creat at that
Okay.
instant as well, just to
Okay.
make sure that what kind of medicines that we can give her, and add calcinase as Prashant added.
Okay. Fine. See, as Martin is not there, I'm just going to ask Dr. Rajesh.
Yeah.
Rajesh, see, in NHS setup in UK practice, so 74, she comes with this, and the radiographers say this is the best they can get. So, how would you able to comment on this, or would you recommend any further imaging, advanced imaging at this stage in your
Absolutely,
practice?
because in here, if this is the best X-ray that we can get, we would advise cross-sectional imaging. So preferably, because it's to do with the spine alone, and if there is no other findings, then we would ask for an MR.
You would ask for an MR.
Yeah.
Yeah. Good. Fine. So there is a consensus that just for delicates, if you have an elderly patient fall, no other cause for fall, it's a mechanical fall, and they have isolated back pain, and the X-rays are clear about a vertebral compression fracture, and it is benign looking, then as panel said, analgesia, review after, if they're able to cope at home, review after a week is sensible. Re-X-ray is very sensible way. So that is, I think, one take-home point to start with. So this patient, as I said, she lives alone and she's with a lot of pain, which is 10 out of 10 WAS score according Prashant. So we were not able to run, analgesia, and we were not able to send her back home because she was not able to coping. So she was admitted, and because the CT, we thought even if we do an X-ray, repeat X-ray, it is going to be the same, and she's not able to stand. Ideally, we want to get a standing X-ray if the pain is bearable. When we see them in the A&E, if the manageable pain, and if you're sending them home to bring them back in a week time, I like to see a standing X-ray to see whether there is how much collapse is happening. They're able to stand in acute stage. If not, then yes, I'm sure when we see them later on. So we got the CT. So we thought CT would show something, and it shows something at the L1. And we gave analgesia, and as you all said, nasal calcinase. So that's one of our management as well. And in this age group, we cannot use a lot of anti-inflammatories or opioids or anything. So I normally use paracetamol and nasal calcinase, vitamin D3, vitamin calcium, and any bisphosphonate to start with. That's what would be my regime to start with. And then once the analgesia is better, we got a standing X-ray. Sorry, what is happening? So we got a standing X-ray. So now I want to know at this stage, so assume this is a week down the line, and she is still in pain. She is still in pain, and she has not got out of bed, and it's a week now. So Rishi, you want to see her in a week now, week down the line, and what would be your approach?
Right. So if her pain hasn't improved at all, then definitely it needs some sort of discussion with the patient, because we know that osteoporotic fractures, most of them heal well with conservative treatment, and the typical time period at which they become better is around 3 to 4 weeks time. But the factor that goes against this form of conservative treatment for her lies she's alone at her home, and she may not be able to cope independently. And second thing is we are seeing an increasing collapse compared to what we saw in the CT scan, which has been taken a week before.
Yeah, we know that because that is supine, and that is the one reason that we want to see standing X-ray.
Exactly.
See how much is collapse on axial loading. Yeah.
Yeah, exactly. So then at this stage, I think we have to give her both the options of waiting for some more time, prescribing some more analgesia, bracing, and then see her at the end of a month, or to go in for a vertebroplasty to relieve her pain immediately.
Okay. So in your practice, what is the cutoff point? If the patient is in pain, but what is your cutoff point for a failed
conservative? Wait for a month. We try to convince them at least for a month you have to put up with conservative treatment. Only if she has a neurology, then only we proceed with some sort of an intervention.
Okay.
It's just for pain management alone, we don't do a vertebroplasty or a kyphoplasty within the first 4 weeks after the fall.
Okay. What about your practice, Prashant? When is the threshold to
after 7 days, if she's still in pain and the VAS score has increased or not improved from the initial level, I would be, my threshold for doing MRI is very low. So I'll get an MRI done and then I see. And then I'm discussing with the patient, because I don't want to discuss with the patient without further information. If I have more information in form of MRI, then I know the progression of our chances of further collapse, chances of our going into non-union.
Okay.
Seeing the X-ray, I am not able to see that. I'll tell you that. So I will get an MRI done at this stage.
See, for the delicates, here the critical point, what Rishi said is you will wait for 4 weeks, because to give a benefit of conservative treatment or natural course, you have to wait for at least 4 weeks, because the nasal calcitonin and healing process will take time. So 4 weeks and is what Rishi's practice and his threshold. As what Prashant pointed out, you would not discuss about any management without MRI. So MRI is critical. Before you plan, you discuss what, with the next course of action. Fine.
Just a quick question, Murli.
Yes.
Just a quick question.
Yes.
Yeah, to both Rishi and Prashant. What type of braces do you prefer? I personally prefer a Taylor's brace, top to bottom. Sometimes even axillary crutches if the patient is in severe pain.
Yeah, I mean, I agree with you, Manish. I will never ask for a LS brace in these cases, because the fracture is 12, so LS braces will actually deteriorate the pain. So is a Taylor brace or a hyperextension brace?
Yes.
Hyperextension brace is difficult to wear on the elderly patient, so Taylor is very comfortable. So yeah.
Yeah, from above L3 level, we give the Taylor's brace, and below L3, we give the L3, L4, and if there is a very rarely L5 fracture, then we give an LS brace.
Okay. So at this stage, it's 2 weeks now. So what we have done is we have also ruled out myeloma, and we have done a DEXA scan to see what is the score. So now we have had a different conservative approach. The importance is wait for natural time if there is no sinister features. Good conservative regime, which includes safest analgesia, nasal calcitonin, vitamin calcium supplements, also initiating the osteoporosis medications. And then comes the brace, as pointed out. A lot of these people are not, Richie, as you know, they are very frail. The brace is also very difficult to fit in, and they may not, it's cumbersome for them. Skin also to take into consider. So we also applied the TLSO brace, but still she was symptomatic. She was still symptomatic, and now it is 4 weeks point. So what we decided, we got after all the sessions she failed, so we got an MRI. So here I have got an MRI, typical MRI, which looks as a benign osteoporotic vertebral compression fracture in all sequences. And I want to highlight, when we screen during the initial stage itself, if you can get a plain X-ray or when you do MRI, whole spine to see, because concomitant fractures, most of the time the one vertebral fracture, they may have a whole healed or subacute fractures elsewhere. So it's better to screen the whole spine and see. So now I've seen the MRI. The patient clinically, it's only the pain. She has a thoracolumbar pain, tenderness, not able to move, not able to go to toilet. She's struggling. No neurology. There's a myeloma I have ruled out. So it's very important to rule out myeloma. And also we've done a DEXA scan to see how depth the osteoporosis. We've done that. Now my question is, when I read this MRI, it's always, I know this is a pathological. So is it this pathological fracture is a benign osteoporotic fracture or a malignant metastatic fracture that I should be worried and doing further? So we will take our expert, Dr. Rajesh Boshu's talk, and I'm sure Boshu will enlighten us with how do you discriminate these benign fractures with malignant fractures. So Dr. Rajesh is a renowned musculoskeletal interventional radiologist from Royal Orthopaedic Hospital, Birmingham, and he's very academic and has done a lot of contribution to the musculoskeletal radiology. So over to you, Dr. Rajesh.
Yeah, thanks a lot, Murli, for that. So I hope you can see my slides. Yeah.
Yes. Yes.
Yeah. Okay. So over the next 5 minutes, I'm just going to show you, as you rightly said. So whenever somebody has a fracture, the key thing is to note whether it is osteoporotic or neoplastic. So whenever you look at an MRI, the key features to look out for is you have to see whether the posterior cortex of the vertebral body, which is fractured, is there bowing or not. If there is posterior bowing, it is neoplastic. The second thing is you have to see if the marrow signal change, if it involves the whole body or not. If it involves the whole body, it is neoplastic again. If there is change in the marrow, the normal marrow signal is altered in the pedicle. If there is involvement of the pedicle or posterior elements, it will be neoplastic. It's not osteoporotic. And obviously, if you have a large extradural mass, extraosseous mass, either in epidural or extraosseous, and I'll show you examples of these, then it is neoplastic. What is fluid sign? So whenever you have a fracture, you normally have fluid within the cleft. So traditionally, if you have a fluid sign, it's more likely to be osteoporotic. And what we have is sometimes on MRI, if you have a wedge compression, I'll show you examples. We can see a band pattern. You can see a linear low signal, then a bit of high signal and a bit of normal signal. And that's what we call as a band pattern. And if you have a band pattern, it is more likely to be osteoporotic. If you have a small fracture fragment with a small retropulsion involving, most commonly seen in the posterior superior part of the vertebral body, that is osteoporotic. And obviously, if you have multiple lesions in the spine, then it's likely to be neoplastic. Sometimes, in spite of all of these, it might be difficult to differentiate whether it is osteoporotic or neoplastic. In those cases, we can use advanced imaging like diffusion. And if the ADC value is low, then it is osteoporotic. And if it is high, it is neoplastic. We traditionally use chemical shift imaging. It takes 20 seconds extra to do this sequence. And you measure the region of interest. And if there is a signal drop of more than 20%, it is osteoporotic. So these are the main features. So let's look at some examples. So in this case, I have a T2 sagittal here, and we've got a STIR sagittal here. You can see 3 contiguous compression fractures on the T2, and you can see osseous edema as well. And the presence of this bright signal indicates that it's a relatively recent fracture. What about this? So this is a T2 sagittal, this is T1, and this is STIR. Obviously, we have 2 wedge compression fractures. You can see this fracture fragment involving the posterior superior part. So whenever you see that, that means it's more likely to be osteoporotic. The second thing I was talking to you about the band pattern. So this is what I call as band pattern. You see a bit of low signal, a bit of normal signal. And when you see MR on the STIR, you see a bit of edema. So if you see a band pattern, it's more likely to be osteoporotic. Another case, we have a T2, a T1, and I've shown a CT. So in this case, you can see a wedge compression fracture, and you can see loss of normal marrow signal. And there's a bit of brightness here. So that means it's a recent fracture. And you can do a CT, and the CT confirms that it's a osteoporotic fracture as well. And another example, you can see in this case, this is a T2 sagittal, a T1 sagittal, and STIR. So there's a wedge compression fracture, but on STIR, there is no brightness. That means there is no edema. So this is a chronic osteoporotic fracture. Whenever you look at a fracture, you have to look at the posterior vertebral body. If you see the posterior vertebral body in this case, you can see there is no posterior bowing. It is straight. So that means it's osteoporotic. When you compare that with these, we have 2 fractures involving 2 contiguous vertebral body. And if you look at the posterior vertebral body, there is bowing. So whenever you see bowing, it means it is neoplastic. It's pathological. It's tumor. And then if you scroll to the side on the parasagittal, if there is involvement of the pedicle, as in this case, you can see there is marrow signal change involving the pedicles. It means it is neoplastic. If there are multiple lesions, in this case, you can see in addition to the lesion that I showed before, there are multiple further lesions. That means it is neoplastic again. The next feature is if you have a large epidural mass. In this case, you can see at the level of the fracture, the large extraosseous mass. That means it is neoplastic again. Sometimes not all signs will be present in every case. In this case, you can see a mild wedge compression fracture. There is diffuse loss of normal marrow signal, but there is no posterior bowing. This was pathological. So sometimes all features might not be present in osteoporotic or pathological, because traditional teaching is that if there is posterior bowing, it is tumor. In this case, there is tumor, but it is straight. There is no posterior bowing. What about the cleft sign? So in this case, you can see that there is a wedge compression fracture, and there is on the T2, there is fluid within the fracture. This is what we call as the cleft sign. Whenever you have the cleft sign, the traditional teaching is it's more likely to be osteoporotic. But in this case, you can see, similar to the fracture that I showed you, a small retropulsion involving the inferior part here, that is also indicative of osteoporotic. But you have involvement of the pedicle and you have involvement of the vertebral body below it as well. So this has a mixed pattern, but this was pathological on biopsy. You can do CT or radiographs, and radiographs will underestimate the problem. In this case, you can see wedge compression fracture, but on MRI, you can see that there is posterior bowing. So this is pathological. So this is the same case that I showed you at the beginning. So this is, obviously there is no doubt this is osteoporotic, but if you want to do advanced imaging, this is what we do. This is chemical shift imaging. This takes 20 seconds to do. And what you do is you put the region of interest and you see the averages. If there's a difference of more than 20%, it means there is intralesional fat. That means it's osteoporotic. Another example, 2 continuous wedge compression fractures. If the clinician wants, means obviously there is no sign to say it is neoplastic. There is no posterior bowing, but you can do chemical shift again. And there is more than 20% signal drop off. So this is osteoporotic. Sometimes all that glitters is not gold. In this case, you have wedge compression fracture of L5. There is a lot of osseous edema. But when you do CT, you can see that there is wedge compression, but there is expansion of the vertebral body as well. So this is Paget's. So to summarize, the features to differentiate between osteoporotic and neoplastic are posterior bowing, whole body involvement, pedicular involvement, epidural mass, and multiple lesions. If you have any of these, it is neoplastic. If you have a fluid sign, band pattern, no posterior bowing or retropulsion with lower ADC value and more than 20%, it's osteoporotic. Thank you.
Thank you, Rajesh. That was a very good summarization, and I'm sure delegates must have learned from it, and a lot of points to discriminate it. One thing I would want to, and as a panelist, want to stress on is every time you see a MRI, an image, try to read the image by yourself and pick up. But that is a very good practice rather than relying on the report. So as you said, there are few features like posterior convexing border and the marrow signal as such. You can see what is the difference of the marrow signal compared to the rest of the marrow signal. And pedicular involvement and soft tissue extensions, epidural mass, these will discriminate from a benign one. Yes.
Quick question to Dr. Rajesh. So we've looked at those fantastic slides at the difference between osteoporotic and malignant features. But many times you've seen that the initial presentation, even on MRI, looks like a fracture, but later it turns out to be some form of infection, especially in CKD patients on chronic multiple dialysis. So how do you differentiate? Do you have any newer sequences, like you were talking about the diffusion weighted sequences or the chemical shifts? Can these be used to pick up such patients? Should be part of all MRIs?
I think so. So whenever you see a fracture, as a routine, we normally tend to do chemical shift, because chemical shift takes 20 seconds to do. Whereas diffusion is a bit more grainier. You need a bit more expertise, B values and all. So it may be a bit more technical. But as a routine, if you see a fracture, 20 seconds extra, and anybody can do it, we advocate chemical shift imaging.
Right, and that can differentiate between osteoporosis versus tumor versus infections as well.
It can differentiate between neoplastic versus osteoporotic. Even in infection, it will be positive, but you have to look at the other things. For example, you will have a bit of perilesional edema. If it is infection, there will be other signs as well. There will be a lot of phlegmon, so epidural edema and all will be there. Unlike
in the very early cases, it's not always present. And most of the centers, at least in India, they don't have these diffusion weighted, at least in the peripheral centers. In the institutes where we work, they are there. But in the peripheral centers, where usually patients get their MRI done and then come, they usually come with a plain MRI, T1, T2, and stir. Commonly people rely on contrast enhanced images. That's the most common differentiating factor used, at least in our country. So your comments on that?
Yeah, I mean, the problem with contrast is we have not used contrast for the last 5 years. There is a lot of controversy about contrast because contrast gets deposited in the brain and in the bones and nobody knows the long-term effect. So we have cut down the use of contrast. So hence I feel that using the basic sequences with some newer techniques like chemical shift, you should be in a position to answer 99% of the queries. There will be 1% where 0.1% where you might have to use contrast, but majority of the cases with basic sequences and chemical shift, you should get the answer.
Manish, to answer your question about the infection, we have faced also the same problem to differentiate between the fracture and the infection, especially osteomyelitis, OVM, vertebral osteomyelitis. So for my practice, I routinely do CRP when I'm in confusion, and I also always do a contrast enhancement. And I have made it so always CRP. If it's plain trauma, your CRP should be normal, whereas in infection it will go high. Plus also contrast enhancement will differentiate between infection and the fracture.
Yeah. Thank you, Rajesh. See, for delegates, I think the plain MRI and a plain MRI, as you highlighted, you need to have a T1, T2 and stir images. Stir images will help you to see whether there is any adjacent vertebra subacute edemas that you can pick up. Sometimes you may want to do a prophylactic cementation if there is any subacute edema on it. So you have to that and other features. Before I close with the Dr. Rajesh, we have a question. What does ADC value mean in diffusion MRI imaging?
So whenever you look at diffusion, you normally get a B value and you get the ADC map, which is the opposite of the diffusion. So if something is bright on diffusion, to see if it is real or not, you have to make sure that the brightness on ADC on the normal map is black on ADC.
Oh.
That means there is restricted diffusion. If it is white on both, that is just edema.
Okay.
But the problem is you have to have software to do it. It takes longer, B values. It's more technical. So hence
it is more of a software driven value.
Yeah.
Okay. Right. There is a question about a DEXA scan. Is DEXA scan not required? As I said, DEXA scan and myeloma screen is a must when you're dealing with osteoporotic fracture. So that's been stressed already. There is another question. We'll come to that later. So shall I go to my screen now?
Yeah, I just like to add answer to that DEXA question. Yeah, that DEXA is a must, of course, but acutely painful patient, you are sending them home on. Hello.
Go on, Manish.
Yeah, Dr. Manish, you're audible.
So the acutely painful patient, unless the patient is admitted, you don't want to. You can't send a patient for DEXA on an OPD basis. For an admitted patient, yes, you must get a DEXA done, but it is not going to change your management in the first month or so of treatment. For the later term, once the patient is comfortable, he's able to walk by himself, can travel to a center, DEXA should be done. But probably earlier, it may not really change your management.
Yeah, absolutely. And DEXA actually is for to see how much he's improving on the anti-osteoporotic medicine rather than treating the fracture itself.
Okay.
So if somebody has fractured, DEXA has to be down.
Murli, hello.
Yeah. Wait, Emma. I will come in. Okay, fine. See, now, so we managed this. She failed. So we talked about the conservative regime. We all agreed that 4 to 6 weeks we do a conservative management, and we get the further imaging. Once if the patient is not improving with the conservative management, yes, everyone would get a further imaging, MRI imaging, and we will make sure it is osteoporotic. And we all know what to look for. What are the features to look for to discriminate osteoporotic into metastatic? And at the same time, we would have done all the blood investigations to rule out myeloma, and DEXA scanning as appropriate. The patient is able to get it or not. And we all know about vitamin D, calcium, and everything. And then, as Prashant pointed out, now DEXA value is needed to see the response to the treatment, and also it gives a depth out how severe the osteoporosis is, and what are their risks for further fractures. So if you add one fracture, there is a high risk that you're going to get a second fracture, whether it's a vertebral or a hip or a wrist. So for that the osteoporosis medications will help to reduce the chance. So here I would like to invite Dr. Hema, very renowned rheumatologist from in our part of country, and she is going to throw and enlighten us about the secondary osteoporosis prevention medications, and which ones and what sequence. Hema, over to you.
Yeah. Good evening, one and all.
You can share your screen. Yeah. I will stop my screen, and then you have to share your screen.
I think you're able to see right now.
Yeah, yes.
Yeah. Thank you, Murli. Thanks for the opportunity. So here another 5 to 7 minutes. What I will do is I'll just give an overview of osteoporosis and the management strategies associated with it, and also like what will be the best drug for osteoporosis depending on their efficacy. So just I'm not able to.
We can see
play.
Yeah, but I'm not able to.
Yeah, play. Scroll. Go to play if you.
Not able to scroll.
So while
okay, yeah. Fine. Yeah. Good. So just a few points about the global burden of osteoporosis. I think you're all aware of these things. Like in India, I'll just try to focus. Like 10% of a population are above 50 years of age. So about 50 million people are either osteopenic or osteoporotic. And this is the last one thing is a study done in Delhi, which shows that 42.5% of women and 24.6% of men above 50 years are either osteopenic or osteoporotic. So as you all know, like among the fragility fractures, vertebra is a commonly involved thing, and it occurs in 25% in the age group of more than 70 years and 50% or more than 80 years of age. And comparing the mortality, the 1-year mortality is 15%, which is less than the hip fracture, but 2-year mortality is almost equivalent to the hip fractures. So history of previous 2 vertebral compression fracture is the strongest predictor for future vertebral fractures, and this patient should be treated as early as possible. So I think this you all are aware of. So any osteoporosis less than 2.5 and severe have associated fractures also. So these are the means by how you measure the bone density. Either you can use a Frax tool, or you have to measure the bone mineral density by these measures. But the most preferred will be the DEXA scan. But there are also other modalities like single energy X-ray absorption meter, quantitative CT, and ultrasound also. But the commonly preferred one will be the DEXA scan. So what are the indications for a DEXA? So any women aged more than 65 and any men aged more than 70 years, regardless of the clinical factors, risk factors, you have to do a BMD for those patients. Younger post-menopausal women and women in the menopausal transition with the clinical risk factors, again, you have to do a DEXA scan. Adult who have a fracture at or after the age of 50, again, there's an indication to do a DEXA scan. And adults who are on like risk factors, but particularly in our conditions, like patients will be on long-term glucocorticoids, so they have to undergo a DEXA scan after the age of 50. Normally, as a rheumatologist, we do a DEXA scan in the patients more than 50 years of age, whenever, because these patients are already on long-term steroids. So here, we're concerned with the vertebra. The indications for vertebral imaging would be the T-score at the spine, total hip, or the femoral neck if it's less than -1 in women, and the women in the age group of 65 to 69 and men in the age group of 70 to 79 if the BMD score is less than -1.5. And in a postmenopausal women and men aged more than 50, when they have these factors like low trauma fracture during the childhood, when there is a height loss of more than 4 centimeters or a prospective height loss of more than 2 centimeters, and as I said already, on long-term glucocorticoids, these are the indications. Whenever you see the patient, definitely you have to ask for a vertebral imaging. So coming to the management of osteoporosis, it has two pathways. One is a non-pharmacological therapy, other is a pharmacological therapy. Non-pharmacological therapy, ideally, it leads like lifestyle management, like weight-bearing exercises, and then stressing upon like maintaining a good like BMI, and then particularly you have to stress them on the walking exercises and other things. And coming to the pharmacology, and particularly in a case of spine, like prevention of falls, you have to tell them about the prevention of falls also. So coming to the pharmacological therapy, you've got a lot of things, starting from calcium, vitamin D, hormone replacement therapies, SERMs, bisphosphonates, denosumab, and PTH. Ideally, you can classify it as anti-resorptive and anabolic. So calcium, vitamin D, HRT, SERMs, bisphosphonate, denosumab, they're all anti-resorptives, while teriparatide comes under an anabolic group of agent. So what are the indications of pharmacological therapy? Whom to start on these therapies? Again, you have to do a DEXA scan. You have to have a T-score before you start them on these pharmacological therapies. So T-score less than -2.5, like it means it's osteoporotic. And if at all, if it's the osteopenic range, like -1 and -2, if the FRAX score is very high, like the 10-year probability of major osteoporotic fracture risk is more than 20%, or 10-year probability for hip is more than 3%. And if they had any recent fractures, like within a year, and as I said earlier, the fractures while on approved osteoporotic therapy, or they have multiple fractures and while on a long-term glucocorticoids. And again, very high risk means like the fracture assessment score is more than 30%, or the hip fracture assessment in a FRAX is more than 4.5%, then these are the cases where you have to put them on a pharmacological therapy. So this I have taken from the recent AAC guidelines. The recently approved drugs which are used in osteoporosis, or this abaloparatide is not available in India. It is available in US, and it's supposed to be a very good drug. And coming to the bisphosphonate, you have got alendronate, you have got ibandronate, you have got risendronate and zoledronic acid. These are the anti-resorptive agents. And denosumab, of course, an anti-resorptive, but it's a monoclonal antibody against a Rankel ligand. And romosozumab is also not available in India. It's available in US. And the one anabolic agent which we have in India is the teriparatide. So I think you all be aware of the dosages, so I'm not going into that. So this fracture reduction with these drugs, all these drugs, like starting from your abaloparatide to zoledronic acid, they have a very good effect over the vertebra. But compared to non-vertebral fractures, their efficacy is very much over the vertebra. So how long to continue the therapies? So ideally, in a case of a bisphosphonate, after doing a DEXA, you're putting them on a bisphosphonate therapy. So oral bisphosphonate has to be continued for 4 to 5 years. And IV bisphosphonate, example, zoledronic acid, you can give for 3 doses, with 3 years. After 4 to 5 years, you have to do a DEXA and also evaluate the risk factors associated. If the T-score has improved, it means the T-score has become more than -2.5 and there is no new or recurrent fractures, again, you can give them a drug holiday. If the T-score is again, it remains the same or less than 2.5 and you have a new or a recurrent fractures, you have to continue the treatment for another 4 to 5 years, but you can consider to give a drug holiday for 1 to 2 years in between. But ideally, they have to continue the treatment. And this is with regarding to the bisphosphonates. Just the take-home point will be bisphosphonate 4 to 5 years and then a drug holiday. Before that, do a DEXA scan and then reassess whether you need to stop or you need to continue. But with regards to abaloparatide or teriparatide, it is for 2 years. And after that, you have to switch over to either an anti-resorptive therapy. For romosozumab, again, it's only for 1 year. After that, again, you have to switch over to other group of agents. But with regards to denosumab, it has to be continued because once you stop denosumab, the rate of decline in BMD will increase. So denosumab has to be continued. But in Indian scenario, like many of the patients will not be affordable for teriparatide or denosumab. So you can just give the required dosage and then you can switch over to other anti-resorptive therapies. So how do you monitor this patient? Ideally, whenever you start on these therapies, you have to do a repeat DEXA scan after 1 or 2 years. Ideally, it will be after 1 year, but it can vary between 1 to 2 years. And some few points about the bone turnover markers. Ideally, we don't do routinely for all these patients, but there are certain conditions where you can do a bone turnover markers. For example, in Paget's you can do, in hyperparathyroidism we can do. But some patients will ask you, like, I have been on these drugs, whether my BMD has improved or whether I'll have a risk of future fractures. So in that case, you can go for a bone turnover markers, because you can do it in the early phase. You need not wait for the DEXA scan for 1 or 2 years, because these markers may take its action within 3 to 6 months. So you can do a bone turnover markers in those scenarios. So the bone, we have got two things. One is bone resorption markers, that is serum C-telopeptide, that is CTX, and you have got NTX, urinary telopeptide. In the bone resorption markers, CTX is commonly done. And bone formation markers, you've got bone specific alkaline phosphatase, osteocalcin, and PANP. But PANP is done, and CTX, that commonly done will be the CTX and the PNP. So what are the uses? As I said earlier, what are the uses of biochemical markers? It predicts the rapidity of bone loss in untreated patients. But for example, if the patient already has a fracture, you want to know the whether they have improved with the treatment or not, then you can go for a biochemical marker. And it predicts the magnitude of BMD increase with the therapies. And also it helps to determine whether the patient has the compliance or whether he is responding to your treatment or not. So in those scenarios, you can go for the bone turnover markers. So again, a few points on, like, we have a lot of questions, whether you have to give only a single agent or a combination of agents. As far as the studies are concerned, no single study recommend a combination of treatment. But there are certain scenarios where you can use a combination of therapeutic agents. Like when the patient has got a high risk for fracture, the patient has already sustained 2 or 3 fractures, and still she's very osteoporotic, you can combine few therapies. A commonly used therapy will be teriparatide. Teriparatide can be combined with zoledronic acid, because teriparatide, it drastically improves the lumbar spine BMD, but again, zoledronic acid increases the hip BMD. So if you want to give a very good effect over both the lumbar spine and the hip, you can combine a teriparatide with the zoledronic acid. And the fantastic combination would be teriparatide and the denosumab, because it causes a very good addictive effect over the bone mineral density. But routinely, we are not using it. In certain scenarios, when the patient is severely osteoporotic and needs a combination therapy, you can go for it. Ideally, we're using these things, sequential use of therapeutic agents, because in Indian setup, in low people who are not able to afford, we can switch over from a therapy to like a teriparatide or a denosumab, which are quite costly. You can switch over to the anti-resorptive agents. So switching from an anabolic agent like abaloparatide, romosozumab, or teriparatide with anti-resorptive agents like bisphosphonates, denosumab is recommended. And switching from a bisphosphonate to anabolic agent can also be done. But switching from denosumab to anabolic agent is associated with a severe loss of BMD in the hip, so it is generally not recommended. So you can switch over from an anabolic to anti-resorptive, and you can switch over from a bisphosphonate to an anabolic agent, but don't switch from denosumab to an anabolic agent, like denosumab to teriparatide. Don't do that. So this is another few minutes. I'll just show how these drugs act over, particularly Murli is very concerned about the vertebra. So I'll just tell you, like among the bisphosphonates, you can see the effect, like zoledronic acid has got a very high relative reduction on the fractures, like it is around 60 to 80%, and then comes the ibandronate, and then comes the alendronate, which is around 40%, it's more than 40%, and risendronate. So it's preferable in a vertebral fracture. If patient is not affordable, I think ideally you can go for a zoledronic acid. And this is again a picture comparing a bisphosphonate with your denosumab. Here again, you can see like this is your bisphosphonate and this is denosumab. You can see a drastic change in the BMD in the denosumab group compared to a bisphosphonate group. So in case if you want to have a very good BMD effect over the vertebra, ideally I would prefer to go for denosumab rather than waiting for oral bisphosphonates. In case the patient is not affordable, you can go for an IV zoledronic acid. And this is one new, this is one trial which I found it's interesting because there is no head-to-head trial which compared the incidence of new vertebral fractures. This is a trial comparing a teriparatide with risendronate. You can see like in this teriparatide group, you can see the incidence of new fracture is very low compared to the risendronate group. So again, teriparatide scores over the risk reduction concerned with the vertebral fractures. And this is actually this is a trial like with the denosumab, where you can see like denosumab has got a very good effect over the vertebra compared to your placebo group. So denosumab definitely has got a very good effect over the vertebral fractures. And this is with regard teriparatide. So here again, you can see in a spine, this is comparing with your placebo. Here teriparatide has definitely got a very good effect over the BMD in a lumbar spine. So this is, of course, this is not available in India, but I just want to focus this. This is an abaloparatide trial, which is called an active trial here, which is 18 months is an active trial. And after that, this is an active extended trial, which is done for 43 months. Again, you can see there are only, this is abaloparatide, only 4 fractures in abaloparatide group, whereas it is 30 fractures in a case of placebo. And when these patients were switched over to alendronate, you can see like 16 fractures here, and here it's only 5 fractures. So definitely abaloparatide compared to all this thing, abaloparatide is a very fantastic drug in reducing the fracture risk. And so I just end up with this. What is the recent guideline? This is American Association of Clinical Endocrinologists group, which is upgraded recently in 2020. So always do a lumbar spine, femoral neck, or a total hip BMD, that is you need to have a T-score, right? So then evaluate for the other causes of osteoporosis, secondary cause of osteoporosis. The primary will be always, whenever you start on either a bisphosphonates or an anabolic agents, you need to supplement them with calcium and good amount of vitamin D3, because for the drug to act efficiently, you need to have the calcium and vitamin D3 in a required values. Particularly, this is very important in denosumab group, because whenever you start a patient in denosumab, you don't check a calcium. They may drastically go for hypocalcemia. So it is recommended to test a calcium and vitamin D before you supplement with any of this osteoporotic agents. So the ideal value will be calcium will be 1200 to 1500, and vitamin D will be 600 to 800 international units per day. But if you want to treat a vitamin D deficiency group, you can substitute them with 60,000 international units per week for 8 weeks, and then 1,000 to 2,000 international units per day for another 8 to 12 weeks. But the ideal value which you have to keep the vitamin D will be more than 30 picogram per ml. That is an ideal recommended values. So then you go for a pharmacological therapy. So this is again, which I said earlier. So high risk, no prior fractures, you can go for your bisphosphonates, either alendronate, denosumab, isendronate, or zoledronic acid. That you can decide depending upon the economic status of the patient and affordability of the patient. But you have to reassess the response to therapy after a year, and also you have to reassess the fracture risk. If there is no the BMD is stable and there is no fracture, you can give a drug holiday after 5 years and after 3 years in case of an IV zoledronic acid. And again, you have to reassume the therapy. But if there is a progression of bone loss and there is a fracture, then you have to reevaluate and you have to switch over to the other kind of therapy. For example, previously patient was on alendronate. Now she has sustained a fracture. You can switch over to either a denosumab or a teriparatide. You can switch over like that. This is with regards to very high risk of prior fractures. In this case, you don't take a risk. So you have to go for an anabolic agent. That will be the ideal thing. So here in Indian scenario, I will suggest to go either for a teriparatide or a denosumab, rather than putting them on ibandronate, risendronate. So for the drug to act, time for action. So you have to put them on a very good anabolic agent if you want to have a very good effect over the spine. So you have to reassess the therapy. For denosumab, again, as I said, you have to continue the therapy unless the patient is affordable. You have to continue the therapy. And ramosumab, I'm not concerned here. And teriparatide, you can give it up to 2 years, and then you can switch over to the sequential therapy, either with the oral or an injectable anti-resorptive agent. Zoledronic acid, of course, you can give for 3 years, and then you can switch over to other group of agents. So this is with regards to the recommendation given by AAC. So this, I end up with this. This is the overall effect of the drugs over the lumbar spine BMD. You can very well see that the bone building anabolic agent definitely has got a very good effect over the BMD. And second, here you can see anabolic and then anti-resorptive. Definitely it's less than anabolic alone, and bisphosphonate here it lies in the lower group. And with this is the incidence of fracture. Definitely it is very low with anabolic agents, and then comes your bisphosphonates, and placebo definitely it has a very high risk. So the take home points will be like I would just in Murli's case, like the patient has got a vertebral fracture, 74-year-old female, directly I would recommend to go either for a For an osteoporotic management, I will recommend either for a teriparatide or a denosumab. If the patient is not affordable, at least I will prefer to go for an IV zoledronic acid. In that scenario, oral bisphosphonates may not help the patients. So ideally, any patient you see after an age of 60 to 70, better to do a BMD and then assess their status, and then you decide the therapy based on the T-score values. So I think that I end here.
Yeah, thank you, Dr. Hema. Fantastic lecture. Just a few questions. We surgeons think slightly differently. So what we know from recent literature is that teriparatide also reduces time to union. So we are usually very keen to start teriparatide after a fresh fracture, provided it is ruled out, it is not metastasis or infection. So probably having an MRI done at 2 or 4 weeks.
Yeah, sure. So
other thing is, we see a lot of trend in our orthopedic friends is that as soon as a patient comes to their clinic with a fresh fracture, they give an IV zoledronic acid. What is your view on that? Does that help healing? Does that prevent healing? Or it makes no difference?
Ideally, we see a lot of cases admitted, like our cases admitted with fractures directly go to the orthopedician. So I'll just discuss with the orthopedician because I just want to know like the healing time and other things. But I will personally advise IV zoledronic acid after a 4-week period. Definitely, I'll start them on IV zoledronic acid. Yeah. I don't wait further because I think 2 to 4 weeks will be sufficient. So I'll just put them on IV zoledronic acid after 4 weeks.
We'll take 2 quick questions from the audience here. One is that in an elderly women, whether to give calcitriol versus vitamin D for osteoporosis or osteopenia. This is question 1. Can you just comment on that?
So ideally we do only vitamin D3. We give only vitamin D3. We don't give other formulations. So vitamin D3, as I said, the recommended dose in a treatment for osteoporosis will be 60,000 international units per week for 8 weeks. And then either you can give us a monthly therapy for another 8 to 12 weeks. Ideally, you have to,
a lot of pharma companies have this fancy calcitriol formulation. So what is your recommendation on that?
I recommend only vitamin D3, sir. Yeah.
Good.
I don't.
Second question is role of nasal spray calcitonin. I think we've already talked about that.
Yeah,
you discussed about it
in the fresh fractures and
fresh fracture bone pain.
Yeah, and for injection zoledronic acid, what side effects are to be watched for denosumab in teriparatide as well as zoledronic acid?
Yeah, the common complication noted with denosumab, because it's a monoclonal antibody, doesn't have any systemic effect, so there will not be any allergic reactions. First point. Second thing is, you have to monitor the calcium phosphorus alkaline phosphatase level before you start them on a denosumab, because the common complication noted will be your hypocalcemic. Some patient may even go for tetany. So that you have to monitor. Coming to your bisphosphonate group, so theoretically, I have not seen any ONJ, so osteonecrosis of the jaw, and apart from all those things, atypical fractures. Even though the BMD increases, we have got a lot of atypical fractures also. So increase in the BMD doesn't mean that the fracture risk is less. Even then, the patient may go for atypical fractures. But the common complication with zoledronic acid is some patients may have like fever or some allergic reaction. So normally we give them a paracetamol or antihistaminic before we put them on those drugs. But otherwise, I don't see much complication with zoledronic acid.
Emma?
Normally we used to, yes, Murli.
Yes. See, we have 2 specific questions.
Yeah.
Before you close up. See, abaloparatide you said, because teriparatide, we have to administer subcutaneously every day. Is it abaloparatide the same or different?
Yeah, but thing is...
Same.
Pardon? I didn't get you. It's also same only.
Is it the
subcutaneous,
abaloparatide.
Same. I'll just show you in my slide.
And it also, okay. It is also the same indication and contraindication like
same as abaloparatide and teriparatide is only, it's a analog of a synthetic protein related structure of PTH, whereas teriparatide is a analog of PTH. It's 134, no, that thing. So it doesn't have much effect, but the effect what they suggest is abaloparatide has got much higher efficacy compared to your teriparatide. I'll just show, I'll go back to that slide, Murli, for your.
Okay. No, that's
so
fine.
you can see. This is 80 micrograms.
Dr. Hema, I have got a question for you.
Yes, sir.
Yeah, you say we do a lot of spinal fusion, and normally in elderly patient after doing a fusion surgery, I oftenly use teriparatide. But is there any indication of denosumab also, or if I have to use denosumab, if that has utility in fusing, when should I start denosumab? After my fusion surgery?
After your
If at all it's
surgery?
useful. After fusion surgery.
Fusion surgery, you can use him. I mean, like that's what I said. You can wait for 4 to 6 weeks because some orthopedicians are very concerned that it may interfere with the healing. So that's why I tell you can wait for 4 weeks and then you can start them on a denosumab or a teriparatide. But ideally, there is no such anywhere recommendation like when to start these drugs. We don't have any recommendations ideally. But normally, when I discuss with the orthopedician, they said we will wait for some time and then we'll put them on these drugs. And of course, anabolic, I don't think so you'll have any effect because it's anabolic, right? It's going to increase your osteoblast. So it is not going to interfere with the healing, right? So I think teriparatide and denosumab is not going to interfere with the healing process is concerned because particularly, teriparatide.
Prashant,
yeah,
see, you know, a lot of Japanese, they give teriparatide for post-fusion from day one.
I also
in patients above 60 years.
Day one.
Yeah.
So my anecdotal experience, though it's very anecdotal, is really good. Most of the patient who was on teriparatide 6 months or 9 months, it fused completely. On the other hand, the patient who are not on teriparatide, it takes 1.5 years for fusion.
Yeah. It accelerates actually.
Yeah. So in the same thing, I want to ask that whether denosumab has the same role or denosumab is not as good as teriparatide for fusion.
See, teriparatide.
Yeah, both denosumab and teriparatide has very good effect over the fusion, sir. I don't think so there is any controversy, but I think Murli can add upon it.
Yeah. See, denosumab works in a different mechanism. It's osteoclast inhibition. But we know teriparatide is osteoblast bone formation. So that is the reason why it is favored in the bone fusion. And also it is more increase the bone density volume in your fractures as well.
I know, Murli, but I want to know, is there any evidence against or for denosumab?
Really, I don't think so. There's any article or journal on this, sir. Probably I can look up on it. Yeah.
Okay, Emma. Thanks, Emma. I think
thank you.
What you stressed out is the role of secondary prevention. The moment you see a vertebral fracture, we have to think about secondary prevention, preventing further fractures. And you talked about bisphosphonate, and affordability is there because you have to initiate something. But whether it is a bisphosphonate, which is cheaper, or if it is a teriparatide, depending on affordability, but you have to initiate. And I think what for the delicates also, one thing is switching from bisphosphonate to teriparatide to bisphosphonate is fine, but switching from denosumab to bisphosphonate is not recommended. Am I right, Emma?
No, denosumab to teriparatide. Anabolic agent. Anabolic agent. Teriparatide is not recommended. Is not recommended.
So switching
from denosumab to bisphosphonate, that it can be done.
And also you can have a combined therapy for benefit, but switching from this is not recommended. Fantastic. Thank you, Emma. That will
thank you.
That was a beautiful overview. We will move on. If you can stop your screen sharing, I will, and then we will have Rishi coming in. So that case, so this failed, and hello, can you see me?
Yeah, we can hear you, Murli.
Yeah, go on. We can hear you, man.
Hello. Hello.
Yes.
Yeah,
yes.
You're audible.
Yeah. Okay. So that case failed conservative treatment when we given all the secondary prevention measures, and then we did a cement augmentation procedure as everyone would consider in the next stage. So we did kyphoplasty, and she had a beautiful, fantastic pain relief, and she was able to stand, and she was able to return to her normal life. And this is what the case ended up with. Here, there was one question, and I just want to focus. Every time I do a biopsy, even if it is a benign, that I know it's a benign osteoporotic, still I will send a biopsy to make sure we are not ruling out, because radiography, everything, ultimately the biopsy is the one which is going to confirm what is the nature. in terms of any malignancy or anything. So that is my practice. So whenever I do a cementation, an osteoporotic vertebral compression fracture, then I will send a biopsy. I just want to know what would be your practice, Prashant. Do you routinely send biopsy?
Yeah. Always.
Okay. What about Rishi?
Yeah, it's always a routine thing. There is no
routine thing. Yeah.
doubts about it. Yeah.
But would anyone do a biopsy first and then do a cement augmentation later on?
I have done this twice in the past when I started practicing. Was very wary about not to doing the cementing in the wrong condition, wrong indication.
Yes.
So I've done twice biopsy, and it turned out to be negative. Then I bank on other things, CRP, and whenever in doubt, I do CRP or contrast enhancement. Now I do cementing, and the
CRP is only for infection, isn't it?
Yeah. The main problem is you are not cementing the infected vertebra. You are cementing a tumor vertebra, it doesn't matter. But you cement the infected vertebra, you land in big trouble.
Yes. So if only when we think it is a osteoporotic fracture, we do a simultaneous biopsy and cementing. If we any doubt that it could be a malignant, even a slight doubt, then I think staged. Would panel agree with it?
Yep.
Yeah. So biopsy is always preferable.
Yeah.
It's only that many times you don't get anything. There is no sample that you can get. Maximum you can get an aspirate. So I said that aspirate for cytology to look for any malignant cells or pus cells. And if that is negative, then I think you're reasonably okay.
Yeah. So here always when it comes to a biopsy, Rajesh, are you there?
Yeah.
Yeah. See, whenever it comes to a biopsy, there is a general, this thing that when we do with a CT guided biopsy, we may not get enough sample and maybe non-conclusive because they do it with a fine bore needle. So probably a lot of the orthopedic surgeons, spine surgeons, we all prefer a percutaneous biopsy done by in the theater because we think with a wide bore needle we get a conclusive sample. So any thoughts or any change, anything that you do in your practice to yield the result of the biopsy?
No, it all depends upon what system you use. So we use Stryker's Confidence, the confidence system. And with that, the bore is normally enough and we normally get a nice sample. But if you use other systems, then the sample will be low. It all depends upon the system that you use.
Is the system based on negative pressure?
Pardon?
Is the system based on negative pressure?
Based upon the gauge of the needle and the tip of the needle, how it catches it. But if in doubt, you can do aspiration biopsy. You can put the needle in and you can take you can just aspirate the sample and send it.
Okay. Right. So now I'm thinking in retrospect. So this lady came in to me on day 2 and then 6-week conservative, and then she was struggling with pain, and then I had to do a cement at 6 weeks once a conservative treatment is failed. Now I'm thinking that in retrospect, if I had done the cementation in a first week or 2, if I could have predicted that she would fail the conservative treatment, and if I could have cemented, at least I would have relieved her pain earlier and she could have had some better quality of life in the last month or so. So that is my question. That would be the question. So could we predict which osteoporotic fracture pattern will fail conservative treatment and a early intervention will merit?
Sure. I mean, you can predict it.
Yes. I think we will have Dr. Prashant, our passionate spine surgeon from Calcutta, to share his views on this. I'll stop share, Prashant.
Yeah. All right. Can I share my screen now?
Yes.
All right. Thank you. All right. So the question we're asking is, could we predict the conservative treatment will fail in vertebral osteofracture? The answer is yes. So I'll give you a case scenario. Let me tell you, this is not the ideal case scenario. This is one of the cases I got in recent months, and I thought I'll put it to make it even. So this is a 58-year-old gentleman who fell down. He missed a couple of stairs of flight and a severe back pain. So this was his X-ray which was done, which shows the L1 fracture. And then somebody in the community with the MRI also. So you look at the hypointense signal change in L1 and as well as L2, it looked like a burst fracture to me. So the middle column was fractured. So this patient was with his orthopedic doctor and who suggested conservative treatment. I'm sure many of us at the time, looking at the pattern of the fracture.
Prashant, do you want to ask Rishi, see what he does? You've given the scene, Rishi, what would you do at that?
So maybe Rishi, what you gonna do after this?
Yeah.
If you have
put up the
MRI,
X-ray, put up the X-ray.
They looked at X-rays. And, and then you have got MRIs. He's still in a lot of pain. He has no neurodeficit.
I think that it's B2 fracture because both the upper and lower end plates are broken, and if you can
absolutely
in the posterior spinous process as well.
And you can see what's going on the posterior ligamentous complex as well. I think it's
fracture in the posterior ligaments. So I think the patient will need a fixation. There is no room for conservative in this patient.
Correct. I mean, at this time with this MRI, it's no brainer that it will be fixation or maybe combination of VA plus fixation. But having the scenario change where you have just a compression fracture and you have diffuse edema in the MRI, just consider that. So whatever. So this patient was conserved by his primary orthopedic surgeon, and he is landed up with this increase in kyphosis, collapse of the vertebra in 4 weeks' time. Then he's landed with me. So that question arises: when should we intervene? What's the time horizon? Can we predict the failure of conservative treatment? Rishi, I am presenting this case as no ideal case for presentation, but having said that, if there was only diffuse edema pattern in T1, no burst fracture, and no posterior ligament fracture, what you will do? Hello, can you hear me, Rishi?
So our first line of treatment would be conservative in this patient.
So you have just T1 weighted image and nothing else. You have got X-ray and T1 weighted image, which shows diffusion, complete diffuse, hypointensive signal changes.
There are studies which have shown that patients who have a complete, they call it as a total signal change within the vertebral body. So those patients are likely to have an increase to collapse over a period of time, and they may benefit from an earlier vertebral some cement augmentation procedure.
So would you consider VA at this moment, or you want to wait in this?
I would still wait because still there may be like a handful of patients who may avoid a surgical intervention. So still I would give a bit of conservative treatment for them.
Good. All right. Okay. So let us see what is the evidence is. So we're looking at the progression of vertebral fracture. You see when 1 week time to 3 weeks time and to the 6 weeks time, it collapses progressively. So how we can predict it? The same other example where you see the lot of edema in the MRI and the vertebral fracture going to collapse and collapse. So there was a study which is done in published in Korean Neurosurgeon Journal where they have predicted the outcome of the vertebral fracture, and they classified the edema pattern in 3 types: type 1, 2, and 3. So type 1 is a diffuse edema, hypointensive signal changes. Type 2 was globular or non-band pattern, and type 3 was a band pattern. And they also have the follow-up MRI, and they have 3 kind of MRIs in follow-up. So one was wedge compression, the second was bioconcave, and third was collapse, complete collapse, which is called deformity. So now coming back to the MRI, if you look at the slide, this is the top one. The L3 is type 3, which is band pattern, and L1, the L5 bottom one is the type 1 pattern with a diffuse edema. And if you look at the outcome, the type 1 completely collapse with complete deformity, and the type 3 end up with the compression or wedge compression type. Another example, this is type 2, which is globular, which is not diffuse, and non-band type, which is end up with a biconcave. So the study shows that early bone marrow edema pattern is significantly correlated with the vertebral deformity type on the follow-up MRI, and diffuse low SI type early bone marrow pattern lead to higher kyphotic deformity. So they're saying if you are picking up the type 1 pattern, they are more likely. So as much as 70% of them are likely to go into further collapse and further kyphosis. So these are the patients, if you pick up early, will be better off with the VA. Another study on the same pattern has come up with the contrast enhanced MRI in osteoporotic patients. They have done contrast enhanced, and they are looking into the osteonecrosis, the area of osteonecrosis. So if you look on the extreme right, there's a huge area of osteonecrosis which is darker, and they predicted that the greater the area of osteonecrosis on the primary MRI, the contrast enhanced, the more chances of collapse and loss of height. So if you look at this MRI, where the shadow in the center, which is black, which is the area of necrosis, and the periphery is the area of bone edema. So if area of necrosis is bigger, or the percentage Y is bigger than the area of edema, then your chance of collapse is much more. So this studies also shows that the chances of having a cleft is far more if your necrotic area is large, and it also serves as a sufficiently indicator to select the patient which might benefit from the active treatment or intervention. Another study which shows what are the risk factors for conservative treatment failure in osteoporotic fracture, and it has a few parameters like age. If age is more than 75, chance of collapse is much more. Higher the BMD, higher the obese patient, more chance of collapse is far more. And BMI, the BMI, higher the obesity is the chance. BMD, lower the BMD is less than minus 3.5, high chance of collapse, which you already know that. And then it's the MFI, which is modified frailty index, which is the elderly patient who have cardiac issues, angina, MI, or COPD. These patients are better off with intervention, early intervention rather than conservative treatment. Nonetheless, other thing is intervertebral cleft. So people with more intervertebral cleft on MRI will more likely benefit with the VA. And the fourth study, which has come recently in 2020, it's also come from, I think, Korea. And they have prognosticated the MRI based on the enhancement of the pedicle. Again, they have done the contrast MRI, and they are looking at whether pedicles have been enhanced or not. If you have pedicle enhancement in MRI, that means your posterior, your middle column is involved. We all know that pedicle enhancement is more in tumor, but even osteoporotic fracture is very, very common, pedicle enhancement. And if you have pedicle enhancement, irrespective whether the patient has a burst fracture or not, you have more chances of patient going in kyphosis and further collapse. So there are three indicators: pedicle enhancement, initial compression rate, and initial kyphotic angle. Whichever is more, the chance of collapse is furthermore. And these are the patients which will benefit from early intervention. Now, so combining everything, we know that what can help us. If you have more than 2/3 of the marrow edema in T1, marrow edema signal changes, the chance of collapse is more. Area of necrosis, pedicle enhancement, and the initial weight loss, the vertebral height loss more than 40%. Age definitely, and the MFI. So coming back to the previous case, I mean the case which I show you in the first, if you look at this as the contrast enhanced MRI, which shows the area of necrosis, which is quite big, which is about 40 to 50%. And if you look at the pedicles, which are also involved, the pedicles enhancing, and looking again at T1 images, the whole vertebra is involved. So the diffuse pattern area is more than 90%. So this kind of fracture pattern or the MRI pattern morphology is going to collapse further. So day 1 and day 4 weeks. So these are patients which need eager intervention. As she said that because this is basically involving almost 3 columns. So definitely you need a fixation this gap. So what do you do? A V alone, a V along with a supplementary fixation, long posterior fixation. So anybody, Manish, how are you going?
Yeah, Prashant, just before we come to that question, just one question. We know that all osteoporotic fractures will heal with some collapse. No fracture is going to heal in its anatomical position. So for the benefit of the delegates, what exactly are we fearing in the type of fractures that the MRIs that you've just described?
So we are fearing how much collapse. I mean, a collapse is if something collapses by 10%, 20%, we don't fear about it. If it's collapsed more than 50%. So can we predict more than 50% collapse? Or we can predict more retropulsion along the conservative line? Then the patient is going to be in a lot of pain and maybe a neurodeficit in future. So yeah, all the fractures are going to collapse, but the collapse has some limitations. I mean, if you have a marrow edema pattern of type 3, they're not going to collapse more than 10, 20%.
Yeah, I think back to Rishi. Yeah, we'll look at options.
Yep. So assuming that she doesn't have a posterior failure, then if it is only a fracture anteriorly, then I would like to do only a vertebroplasty.
So in this patient, I mean, you have seen the CT, you've seen the X-rays.
Then vertebroplasty along with the supplemental fixation, the option B would be the better one.
What about Murli?
Same, because the PLCS seems to be involved in it, so yeah, I would keep that in mind.
And Manish, what about you?
Yeah, I would go percutaneous, one above, one below, and cementing. I'll show some interesting case in one of them how I deal with it.
So I did the same thing. I did the percutaneous fixation. This is the Indian implant, and I did the kyphoplasty. So this is the post-op, and I could restore the kyphotic angle. Patient mobilized same day and discharged the second day. But the question is, had the patient, I got the patient in the day 2, would the treatment be same or different?
Yeah, that's a very interesting question, Prashant. Would it, if this patient was saying, Dr. Saab, you do whatever you want to do on the 7th day of treatment, would you add fixation or not? Or would you just do a kypho or vertebroplasty?
Correct. I know what I'm going to do, so I'm just asking the panel. Are they going to do differently or going to do the same?
See, Prashant,
not do a vertebroplasty if it is a day 1 surgery.
No, you have the same MRI, you say MRI where they're particularly enhancing. You have bone marrow edema, which is
if you fix it, it's not
more than 100%. Manish, are you going to do differently or the same?
Oh, I would still fix it. Because there can be.
Yeah, for me, if the patient is presented day 1 or first week, if it's a PLC is involved, then there is a posterior tension band failing, and that especially at the thoracolumbar is the more kyphosing force. So I would supplement it with the posterior stabilization.
Along with something PMA
cementation, yeah,
I agree. I will do the same thing. I would not, particularly in this case, the treatment is going to be same. Fixation with supplementation. Okay. Yeah, thank you.
Thank you, Prashant. See, treatment, certain osteoporotic patterns need early intervention. However you treat, they may end up with chronic pain, and they will conservative treatment, and they will need something doing. So if you do that, pick that up early and do it early, you are relieving their pain, they're improving their quality of life and the suffering they have for the period of conservative management. Right. So look for the features and pick early and yes.
Yeah. So for me, I know MRI, my threshold for doing MRI on osteoporotic fracture is very low now. 2 reasons I want to pick because I've seen a lot of tumor metastasis in C+ age group and pattern of the edema. So if the pattern is not very favorable, I will go very early intervention rather than waiting for 4 weeks for vertebroplasty.
So I think, Prashant, you brought up a very nice issue, because initially we were saying conservative management, people who do plain X-rays and they wait for some time before have a low threshold to the MRI and study the characteristic, whether this will fail or this will have a favorable natural course. So that's a very valuable point. Absolutely. So depending on your practice, if accessibility is there, I think we should get a early MRI. That would be the take home. So that will differentiate the malignancy as well. That will differentiate your malignant fractures as well. Okay, what looks benign in X-ray may be a malignant one. Right. Fantastic. Good.
And the scenario, today's scenario is so much of medical legal problems. If you miss a match or malignancy, there's going to be a lot of litigation nowadays.
Yes.
So my threshold is very low for MRI now.
Yes.
For many reasons.
I think that would be reflection of practice in depending on institutions. Yeah, that would be the. See, now we know that certain fractures will fail, and we'll have to do so that we can predict and do early, or a failed conservative treatment will end up and we'll have a cement. And I would like to say that not all non-unions are symptomatic, but same time the non-unions can go into avascular necrosis. We know that from for the bones, if they are non-union, there is a risk they can go into avascular necrosis. So what if a vertebral compression fracture managed conservatively, and what happens if it goes into a avascular necrosis? Again, not all avascular necrosis is symptomatic, and what if it becomes a symptomatic avascular necrosis? So here I would like to invite Dr. Rishi Khanna. We all know him as a renowned spine surgeon from the the holy place of orthopedic surgery, what we call Ganga Hospital from Coimbatore. Rishi, over to you.
Yeah, thanks.
Yes, somebody has to mute.
Right. So the patient is a 55 years old female patient, postmenopausal for 6 years now. And she presented to us with a history of low back pain for about 3 months duration. And she had a history of trivial fall 3 months back at her residence, after which she was able to move about, and her pain reduced over a period of 1 month time. And again, at the end of the first month, she started having increasing pain in the low back region. And at present, when she presented to, she had severe pain in the, she was unable to even turn in the bed. She was brought in a stretcher, and getting up from the bed was very painful. And she didn't have any neurological symptoms, no radiculopathy, no sensory disturbances, no bowel or bladder disturbances. And this was the X-ray which had been taken initially when she had the fall, and the surgeon had treated her conservatively with a brace, thoracolumbocervical orthosis, and calcium and analgesics. And he didn't do an MRI scan at that time, and no further workup regarding whether she was osteoporotic or not. And interestingly, she was she had multiple comorbidities, and when we evaluated her, her random sugar was more than 600, uncontrolled diabetes for more than months together, hypertension, chronic renal disease, hypothyroidism, and she was 143 kg. As you can see from the soft tissue shadow over the low back region, you can see how obese she is. And the examination was pretty much normal. Her neurology was normal. We couldn't assess her gait because she couldn't even stand and walk a few steps because of the pain in the lumbosacral region. And this is the X-ray taken at the time when she presented to her. So obviously we can see there is a collapse of the L1 vertebra, and we can see that a dark black shadow within the vertebra. So that indicates that there is an osteonecrosis of the bone, and this is described radiologically as the intraosseous vacuum cleft sign. And this is the very typical classical CT images which we get when a patient has an intravertebral vacuum cleft. So as you can see, the upper part of the vertebra has a dark black shadow indicating that there is a gas collected inside. The lower part of the vertebra, you can see it is sclerosed compared to the rest of the bone. So that means that the lower part is started to heal, whereas the upper part has developed a avascular necrosis. So this has been described by Kummel, and it is called as the Kummel sign also. So it is a radiographic sign where there is avascular necrosis of the bone with a gross corticocancellous disruption. And in the absence of fracture union and persistent mobility, the cleft margins become increasingly sclerotic, and the center region filled with the gas becomes more apparent radiographically. And this is the MRI images. So this is the T2 weighted image, and one on the right side is the T1 weighted image. So as you can see, both are showing dark signals. So interestingly, if you do the MRI, allow the MRI to be taken after some time, after the patient lies in a supine posture, slowly the gas is filled with the fluid inside the vertebral region, and you can see a bright fluid signal. So some of these patients may not have the gas all the time, so they will have a fluid hyper bright signal in the T2 weighted images straight away in the MRI. But there are other set of patients where in the initial sections it will look like a hypointense in T2, and after a period of 30 minutes or so it will become hyperintense. So this is the stir sequence. Again, we can see hyperintense signal changes. And we have already discussed the predictors of failed conservative treatment. So one thing which I wanted to highlight is there is a classification described by Sugioka et al., where they have seen the initial radiographs and classified them into 5 different types. Those types which have been highlighted in the top row. So the swelled front type, or there is a bow-shaped type, or the projecting type. Wherever there is a break in the bone within the body of the bone at the level of the corticocancellous junction, they have a higher tendency to develop this osteonecrosis. So this is one more patient. So you can see there is a linear hyperintense signal in the T2 image and a hypointense signal. This is the fresh MRI taken at the time of injury. Right, and this is the X-ray and CT images after a period of 3 months, and as you can see, there is an increasing collapse of the vertebra. So that linear hyperintense signal within the substance of the vertebra indicates us there is a break in the bone, which will future lead on to a osteonecrosis or a Kummel's disease. So plan of action, we can do either a vertebroplasty or a kyphoplasty or an instrumental stabilization in this patient. And the advantages of vertebroplasty is you don't need to create a gap, and you don't need a fancy instrumentation like the kyphoplasty. You pass a needle inside the region where there is a cleft. You can either use a unipedicular needle or a bipedicular needle, and then inject the cement straight away. The only disadvantage of vertebroplasty is that there may be a situation where you need to give a lot of pressure, and the chances of cement leakage is high, and you can't increase the size of the vertebra by using an instrument. So you rely on the prone position. Whereas if you are using a kyphoplasty, you insert a balloon inside the collapsed vertebra, you increase the height of the bones, thereby you correct the kyphosis, and then you inject the cement. So the cement is also injected under low pressure. So the chances of cement leakage is much lesser when you do a kyphoplasty. And there are specific indications for adding up an instrumentation along with the cement augmentation, which will be discussed later on. So in this particular patient, we did the percutaneous L1 vertebroplasty, and it was done under local anesthesia because, as you can see, that she had multiple comorbidities. So we gave IV sedation, local anesthesia, bipedicular approach, infiltrate the periosteum close to the pedicular entry, and then do a vertebroplasty. So this was the post-procedure radiograph. As you can see, even by prone position, she was able to open up her the cleft nicely, and then the cleft was filled with cement. Thank you.
Yeah, nicely done case, Dr. Rishi. One quick question.
Yep.
Usually in these Kummel's lesion, you have just one very thin wafer of an end plate above the fluid, and you have a chunk of bone below, assuming it's an upper end plate cleft. So are you worried that the cement is going to break through that wafer of bone in a delayed manner, or it usually heals well?
Right. So the important thing, if you have a very small region of the Kummel's disease or the cleft, then you need to read images clearly where exactly you have to land your needle. So if it is in the close to the anterior 1/3 of the vertebra, then you have to insert the needle exactly in that region so that you don't land up elsewhere, and the amount of cement that you may need to inject is also much higher. The second thing, if the cleft is small, you don't need to inject too much of cement. So whatever the cleft can take, only it can take. So more than whatever you are injecting is going to leak into the perivertebral space or into the intradiscal region. So there is no limit to the amount of cement that you can inject in such cases. So keep your cementation as less as possible.
Right.
Murli, we are not.
Hi,
Murli. Yeah, Prashant.
Yeah. So in Kumel's sign where there's a cleft, so would your preferable treatment will be a vertebroplasty or kyphoplasty? And
if it is Kumel's, always it is a vertebroplasty, because we don't intend to increase the height. Only if it is a patient with a vertebral collapse where you don't have a cleft, then you need to increase the height by using a balloon.
Yeah. Also, the vertebroplasty, I think, is better for interdigitation of the cement into the bone, which the kyphoplasty can't do it.
Yeah.
Even I prefer vertebroplasty.
Yeah.
So before we move on to the need for implant in osteoporotic fractures, I just want to summarize and highlight what Rishi pointed out and others pointed out. See, we agree failed conservative treatment is going to need a cement augmentation, and we have vertebroplasty and a kyphoplasty. And there is a lot of queries, which one to do. Basically, for the patient, the pain relief is given by both procedures. Both procedures gives an immediate pain relief. Yeah. The cement leak, yes, is high, about 30% in a vertebroplasty, and the idea behind kyphoplasty is give a contained cementation, but still it does have a cement leak, about 10% and 30%. But most of the cement leak is asymptomatic on the, most of the whites. And as Rishi said, it will only take the amount it will. So there's no point in being overzealous. So the amount of cement you put in is important. And if you try to fill the entire way, then yes, it's going to extravasate. So that we will discuss in the complication sections. And regarding, there is always this thing that, kyphoplasty restores the height and kyphoplasty restores the angle. But if you look at all the studies, all the RCTs, all the meta-analysis, there is no difference. What looks better in X-ray does not necessarily translate to increased outcome. So vertebroplasty and kyphoplasty, the same outcome for the patient, though X-ray look good, but that does not make more difference for the patient. So that is what the whole of the literature is out. So choose whichever one you want. Yes, cement leakage come with kyphoplasty. That does not give a increased pain relief or anything. So that is one thing between vertebral and kyphoplasty. Anything you want to add, Prashant?
Yeah. Regarding the outcome is same, definitely the pain relief is same. But if you look at the many recent papers have looked into quality of life, and the people who have gone for kyphoplasty have better restoration of kyphosis, and they have better quality of life. Yeah. So recently I saw there are many papers on this. So my practice has changed a little bit.
There is many papers?
Yeah, many papers now. Now more than 7-8 papers are there. So my practice has changed completely now. So what we try to do in our hospital is we do most of the patient kyphoplasty. To cut the cost, we use the balloons, reuse the balloons which are issued previously. And now my practice, majority of time I do kyphoplasty rather than vertebroplasty.
Interesting.
Yeah. What about you, Manish?
Yeah, in a Kumel's region, I don't see a role of kyphoplasty.
Not in a Kumel's region. I'm talking about vertebroplasty and kyphoplasty.
Yeah, I usually tend to do vertebroplasties. I don't see any difference. Most of the height restoration you get by prone positioning itself. So kyphoplasty doesn't add much rather than the cost. And vertebroplasty, I do by particular make sure the cement fill in the fracture crevices is good and the rest of the basics. So I don't usually commonly use. Our hospital is NABH accredited, so we don't get to reuse the balloons. Yeah. So
my hospital is JCI, but used to get
fine. See, for delegate's point of view, see, vertebroplasty kyphoplasty is no difference. Restoration of height or vertebral height does not necessarily translate. There's enough evidence out. As Rishi pointed out, even in a Kumel's lesion, you can do vertebroplasty. What he said, the needle placement. If you're planning a vertebroplasty or kyphoplasty, Needle placement is important. Where is the deficit? Where you need to place the needle? Where you need to, and you look for other features, whether it will leak or not. So pre-plan and place the needle perfectly, and don't be over jealous. Prashant, what is your threshold? What is your volume of cement for a single level vertebroplasty with a 30%?
I mean, it's not fixed. I mean, I try to fill the fracture part completely.
Okay.
If just the upper end plate is fractured, then I try to fill the upper end plate. And if both the end plate is fractured, then I try to fill both the upper and lower end plate.
Okay. Rishi, what is your?
Yes.
What is your?
If it is for a Kummels, then depending on the size.
Not a Kummels, normal vertebroplasty. It was a simple vertebroplasty that we are going to do.
I tend to keep it less than 4 ml.
And Manish, yours?
Yeah, between 3 and 5 ml. Maximum 6, but 3 to 5 ml.
And Prashant, yours?
I never put 6 ml in my vertebroplasty.
Okay.
I could never put.
Oh, yeah. See, what we know is, as Rishi initially said, it will only take the volume it has. So ideal is 3 to 3.5 ml per vertebra is sufficient for pain relief and structural support. Anything beyond you try to push, it will extravasate. So that is
I think if it is less than 3, then your pain relief won't be sufficient. There are enough data actually. If your cement filling is less than 3 ml, the less pain relief.
3 to 3.5 ml is what minimum you need, and that is sufficient. Whether you're doing a unipedicular or a bipedicular, that is what volume needed. Fine. Okay.
And if
so
you're
now
doing
we
a kypho,
have
then definitely more.
Well, yes, depending on the void, how much you're creating on, how much you want it. Like, so now we have, we've seen how we deal with the vertebral compressor fracture with cement, and there are a lot more challenging situations where cement alone is not going to be sufficient, and you need to consider supplemental fixation. And there comes, we know they are porotic bones, they're soft, and chance of implant failure are very high. So we will see now a series of cases, and what are the types of implants and armamentariums you have on strategies how to prevent the failure. I will hand over to Dr. Manish Kothari, who is an expert from Bombay.
Right. So I'll quickly go through my cases. Yeah. Is my screen visible?
Yes, Manish.
Yeah.
Right. So yeah, just a quick case. So Prashant, we can predict which one are going to collapse severely. So this is one case for you. 65, female, diabetic, hypertensive, chronic alcoholic, roughly 4 units a day. She's a smoker as well. Lives alone. She had a small trivial fall at home from standing height. She had pain for about 2 days. She started taking pain medications by herself, went to a family physician, got this X-ray done. How would you proceed from there, Prashant?
So she's 65, 2 days of fall. Yeah, 2 days of fall. If she comes to my office, probably I will see clinically whether she has any red flags, any histories of previous cancer, any weight loss history or something. If everything is negative, probably treat her conservatively.
Yeah, so that's what the family physician did as well. He gave her NSAIDs as well, calcium, vitamin D, nasal spray. But bed rest, she was not compliant. As I said, she was living alone. She had to do much of her housework, cooking, and other things. So she continued with the pain, but one day it got, about 2 weeks later, the pain got unbearable. She cannot stand or even walk more than 2 minutes, barely reaching the bathroom. Daily chores have become painful. VAS score is 8. So what do you do next?
Yeah, I'm going to do MRI now.
Right. So I did an X-ray first, and that's the X-ray. So what do we see? You see that there's a vertebra plana, that's D9 level. How do you go ahead? So I'm just going to wind up quickly. We have bone profile I did. There was everything was normal. M-band was negative. I got an MRI done. So that's the MRI. That's a T2 image. There's not much of a signal on T2. T1 also looks partly sclerotic. They're just unstirred. There's only the posterior 1/3 is showing lighting up. This is a contrast image. We got a CT done as well. As you said previously, Prashant, there's a pedicle edema as well here.
Yeah.
So probably that led to the collapse. There's a cleft sign now. So this is like a Kummels.
The extreme right is the contrast, right? Extreme right?
Extreme right is the contrast, yeah.
So you look at this is necrose. The bone is completely necrose. So that
exactly,
patient will have cleft.
Yeah. So
See,
this one
here,
has,
here, Manish,
yeah.
can I just interrupt? Here, I would like to highlight, what Prashant said. He's changed his practice because he has low threshold to do MRI now, so he can
Yeah.
predict. See,
Yeah.
this, if a day one or within, if affordable and an institution that is a practice, probably you would pick up all those things and you will,
Exactly.
counsel the patient, I think, accordingly.
Exactly.
Okay, go on. Yeah.
So, yeah, so as you can see, there's a breach in the spinous process as well. There's a break here, and there's the ligaments are lighting up on contrast. This is the position I got on prone positioning under G. Obviously, I've operated on the patient. I'll just show what I've done. So this is the X-ray, this is the MRI, and that's how it is opening up on this thing. So now the question comes, what do you do? Do you do vertebroplasty? Do you want to add something?
So,
yeah, Dr. Rishi, what's your plan on this?
The thing is that I would like to instrument also, because the extent of collapse what we are seeing is much severe in the I think it's a standing radiograph.
Yeah.
There is the posterior ligamentous instability as well, and looking at the extent of osteoporosis in the adjacent bones, if you inject a lot of cement in this patient, the chances of segment fracture is also much higher.
Yeah.
So to fix also at the same time.
So exactly my concerns. So I decided to fix the patient. Only thing is that there was some cost constraints, so I could not, patient could not afford fenestrated screws. So I did an open vertebroplasties and screws, cemented screws. Not the best way to do it, but within the cost constraints, that's what we did, and we got a reasonable result. At 1 year follow-up, at least so far, she is doing well. Of course, she's on teriparatide and anabolic agents, and she's doing well.
Was she very porotic on putting the screws?
Yeah, she was very porotic. She was very
All right.
porotic.
That's why you had 3 up, 3 down.
Yeah, that's right. Usually I go 1 or 2 maximum, but she was very, very soft. So I went 3 up, 3 below.
Manish, it was a beautiful case to show that, the vertebraplana, what looks vertebraplana standing, it opens up on a prone positioning.
Exactly.
That is a good
so
thing.
That's the height restoration that we were talking about, So kyphoplasty would have achieved the same thing. So you don't really
That's
need
right. Yeah. And other thing I want to stress is, see, when it comes here, why did you choose 3 level? Why not 2?
Just very soft.
So we all know, but do you want to throw it for the purpose of the delicate? Because very important, the principles of fixation here.
Yeah. So again, in osteoporosis, it all depends on your anchors. So anchors have to be good and more in osteoporosis. In mildly osteoporotic, probably you can go 2 above, 2 below, or even 1 above, 1 below sometimes. But if it's very soft, then cement augmented screws are known to increase the rigidity of your fixation. Then you need to converge your screws, try to have more convergent screws than straight screws. The chances of pull out are less. Fenestrated screws are better than solid screws in your osteoporotic fractures. Always reconstruct anteriorly, whether with a cement, sometimes even with a cage if a cement is not feasible. But anterior reconstruction is equally important.
Yeah. Right? See, I think the point you said is, the fenestrated. Yes, not everyone has got, every patient can afford, or every, practice can afford a fenestrated screw. But what you did is a very fantastic job. You don't need a fenestrated costly screws. Even without that, you can still serve the purpose by injecting, the free and open technique. And multiple fixation. If you go back to your MRI, you can see the diffuse marrow is osteopenic. Severe osteoporosis, you can see everywhere. So the multiple fixations, anchors, you mean the screws, 3 above, 3 below. Yes. So those are the strategies which should help. And the screw length, I see you got up to the cortex because there is a purpose for it. So you want a long screws and a wider screws and a cement
convergent screws with cement augmentation. That's the general principles.
Yeah.
So showing us, I'll just proceed, Murli. I'll show my cases and then we can have the discussion. I'll skip the theoretical discussion. So similar case. Now this is a 86-year-old female, not very, otherwise physiologically fit, just hypertensive. She actually flew down from UK to meet her family in Gujarat, but she had a fall and she was bedridden. She was put on teriparatide by local doctors. Vitamin D since 2 months, not improving. Her VAS is 8, cannot walk 3 to 4 minutes, but no deficit, no constitutional symptoms. ESR is normal, M-band is normal. Got an MRI done. Now, how do we proceed? So we have sitting and supine X-rays. How do we proceed?
See, when you say no deficit, the the osteoporotic fractures are very rarely present with deficit.
Yeah.
The acute osteoporotic fractures.
Yeah.
Yeah.
Is
So,
she a walker,
that's what-
Manish? Is she a non-walker
Barely,
or
just
walker?
with support, she goes to the bathroom. That's all.
But in supine position, she is fine, right?
Supine, she's fine. Yes. Supine, no pain, but as soon as she wants to turn on one side or sit up, there is difficulty eating as well. So.
Okay. See, again, look at the MRI. You can see the convex bulging border. And
yeah.
So ruled out known malignancy, and there is no other. That is also my cause. Is it purely osteo? There is that is one of my concern.
Yeah.
I would do a CT, staging CT to make sure she hasn't got any known primary before I will plan for an.
Yeah, this looks fairly osteoporotic, Murli. There's a cleft, there's a bicortical fracture. That's not ballooning, that's the burst component. I would call that as a burst component.
Yeah, that is retropulsing. Yeah.
So I want to just highlight one thing here, Manish. If you look at the X-rays, most of this fracture is 2 months old, right? In
it's
2 months, 2 months time, the posterior part gets healed, is sclerosed, but the anterior part, which is short, which is opening up.
Yeah.
Majority of this fracture is unstable anteriorly.
Yeah.
But posteriorly, they are healed actually.
Yeah.
You know, the middle column is healed.
Yeah.
So you know, it's a matter of choice for you whether you want to just kypho here or you want to put supplement here. So if there's no.
With that vertebra plana, Prashant, with that vertebra plana and that pincer component, both the end plates are gone. The anterior 1/3 is separated from the anterior 2/3 is separated from the posterior 1/3. Do you think kyphoplasty or vertebroplasty alone will be
She's
sufficient?
86, right?
86.
I mean, looking at the age, I mean, the comorbidity. If she is fit to go for some instrumentation, yes. If not, then I will definitely will go for a kyphoplasty. I mean, if the patient is medically not that fair, and I think it's detrimental for her to put some screws, then I probably do just instillation kyphoplasty. So at least I can make her life better, pain relief, and mobilization.
Right.
I mean, it's a call which you have to take as a clinician.
Yeah.
How's the medical condition?
Murli, what's your take on this?
See, on the supine, I can see there is opening. There is, is opening compared to the sitting. So, and the posterior ligament is probably intact. It is kyphos, or there is no kyphos. So probably, I will go with Prashant. We'll do a kypho and a cement augmentation.
Right, Dr. Rishi, any inputs?
Yeah, for me, it looks like a case for an instrumentation, and along with the instrumentation, either I may put a cage anteriorly going through the pedicle, and then.
She's 85, Rishi.
86.
Sorry?
86.
She's 86, yeah.
If it opens up nicely in the prone, then add a vertebroplasty. Otherwise, still I will be. It's easy if it is a osteoporotic bone. It comes off from the posterior.
Yeah. So I did something. There was some widening in the inter spinous space, but not frank disruption.
The stretching of the ligament. Yeah.
Yeah. I did something out of the box here because she was 86. I didn't want to do a long instrumentation. So I did a vertebroplasty. There was a good fill, but I thought I should instrument as well. So I used our fracture component, the burst fractures principles. I added fracture level screws as well. And 1.5 year follow-up, touch wood, she's doing well. She's back in UK.
Good.
Yeah. So, you're lucky. I would say very lucky, because I would be very happy with instrumentation. If I do instrumentation, I will go 2 up, 2 down at least. Considering the osteoporotic fractures. Either I will do kypho alone, or if I have to do instrumentation, I will do 2 up, 2 down at least.
Yeah.
Again,
with cement augmentation, cement augmented screws. Yeah.
Okay. Fantastic. So again, Manish, I think you're reiterating that the anterior support for this one vertebral.
And you look at this. You have opened it too much. It has really opened up well.
This is all on prone positioning. I have not done anything. I have not put a balloon. This is all on positioning alone.
Yeah, absolutely. If my guess is, if you could have done only cement, probably should have
Yeah, Prashant, I agree with you. Especially 86, you want to do only cement. But if there is a coronal split, I tend to add instrumentation. I don't do.
And also you're worried. I think also you're worried, Manish. The posterior ligament is,
there was some widening, yes.
Widening, and you're worried.
My reason to add instrumentation was the split. Both end plates fractured with a coronal split. So that was my indication.
Yeah.
You think the tension band will fail over the time? See, though 86, 85, she is, functional demands are high. So probably, what you did was wise. You have another case to sum up before I go for the
first just one quick case. So this is an osteoporotic chance fracture, 70-year-old male. He was on steroids for interstitial lung disease, very mild. He had a fall from 6 feet height. Severe back pain presented within a day, same day rather, but he had deficit as well, 3/5, more like the Cauda-Equina syndrome. But the catheter tug sensations were present. Lower limb power 3/5, reduced sensations below L2. Got a MR and CT done. That's a B1 component, and there's also a vertical spirit. There's a burst component into the canal. So, and it looks porotic. There are vertical striations on the CT.
Manish, we have 7 minutes because the bandwidth will go on. So you want to summarize what you're saying?
Yeah. So again, so B1 fracture chance. So whether you want to add a cage in this or not, I chose not to. I added decompression 2 above, 2 below, as Prashant said. But I'm a fan of fracture level screw as well. So I added a fracture level screw along with cementing. I'm adding a series actually. I've got 7 cases of so far in porotic fracture level screw plus cement. Hopefully I'll publish it soon.
Yeah. See, as we said, the osteoporotic fracture very rare to present with deficit, and this is one of the rare cases where there are scenarios where they present with deficit. That's why you need to do decompression, and the instrumentation principles are the same. Yeah, the multiple anchor points and cement augmentation. So we will move on to the loss. I will just quickly show post vertebral instability, and then we'll sum it up with the complication. Manish, can you?
Yeah, I have got one case to show. It's a very interesting case. You can show your case, and I can show my with osteoporotic fracture with a neurodeficit.
Yeah, Prashant, we will have to cut short because complication we have to touch base before we finish because the bandwidth is going off, so we may not be able to support it.
Fine.
Okay,
fine.
So this is can you see my screen? Hello.
Not yet.
Not yet.
Yeah. Can you?
Yeah.
Yeah. Yeah, Murli.
Murli, your mic is not on.
You're muted, Murli. You're
Can
muted.
You hear me now?
Yeah.
So sorry about that. This is a 76-year-old gentleman who had a L2 vertebroplasty, one of the first vertebroplasty in Chennai. He did very well, 76 rheumatoid, and he came and months. And what is happening? It's not okay. Then you can see is a series of X-rays, plain radiographs, AP lateral. In the lateral, you can see standing lateral. The vertebral body has collapsed over the cement in the cemented vertebra L2, and then in flexion extension, you can see some motion, vertebral instability, and also disc lower disc vacuum phenomena, some instability at the collapsed vertebra. The CT clearly shows the vacuum and the lower disc and how the vertebral body L2 has collapsed. The supra adjacent vertebra is fine, but the infra adjacent disc and the actual cemented vertebra has collapsed. So this is what we did is we did open stabilization to about 2 below, applying the principles, and did a decompression, and we did a cement augmentation with a discoplasty because the backup phenomenon was there is some inter-instability, so discoplasty targeting the disc, and the patient did very well post surgery and is happy, is very ambulant, highly demanding guy functionally. I just want to say the post-vertebral instability is very concerned, long-standing effect of the cement on the vertebra and adjacent segment. So the soft bones, osteoporotic bone can collapse and the plates can succumb, and the adjacent disc gets higher pressure, stress. So over the time, it can give us some instability. So the post-vertebral instability is intra or inter, depending on where the apex. If intra is within, so the same body, cemented body, the instability is, then that's intra. If it is adjacent segment and the disc, that is inter. So in that case, I've shown it had a vertebral body and the adjacent segment below. So it's a combination of intra and inter. So because nowadays patients are living longer and the functional demands are high, so this cement, the rock we call, between the cushion, soft bone and the disc is going to be tested for durability. So this is one long-term concern that we need to keep in mind as a cause of concern. And it is good work by, I think, Vishal Kundani and the team on the vertebroplasty instability. I think we will have the complications. The cement leak is the one thing which we worry, and most of the cement leaks are benign, and most of the cement leak is benign, and asymptomatic, and some are malignant, the ones which go into the canal. But that is the one which is we have to watch out. So just give me a second. I will summarize this. See, cement leak is a concern, and when we do, so the keyhole, Jamshid needle, fluoroscopic guidance. So very important thing I do when my practice watch out for is once the needle is past the pedicle and vertebral cortex, I check in the AP, make sure they not breach the medial canal. So if you breach in the medial canal, means there will be a interspinal leak. So that is one thing I would stress on. And then we do the, as I say, you can see the balloon is being inflated, and then you get a contained cavity. So I know I'm not going to leak, but still you can see there was some leak I can see in the spinal canal. It is, even it's contained, the vertebral venous plexus are connected. So there can be a leak. So I just watch it. The moment I see anything, I will stop it. So that intraspinal was a benign, so no issues. And sometimes it can, as initially we pointed out, if we put too much cement, it can go extravasate everywhere. It can go into the intradiscal, it can go into paravertebral, and most of the time they are benign. But if it goes into the vasculature and it gets in the pulmonary, can have a pulmonary cement embolism. Pulmonary cement embolism, most of the asymptomatic, you just do a chest X-ray, you manage. But symptomatic ones need a medical management. So yeah, whenever you see an intraspinal cement leak, then it's worth doing a chest X-ray and make sure there is no embolism in there. So that is the key thing. Always read your images, plan where to put the needle as stressed initially, and also cement. I wait for the cement to set and then put. I don't put it in the liquid or runny phase. That's the time where it extravasate. So avoid too much cement. And the monitor II, and any suspicion, you stop it. I will hand over to Prashant to say what complicated cement leak could be.
Stop sharing, Murli.
Yes.
Are you?
Wait. Yes.
Right. Let me see where it is.
Yeah, bring up. We'll summarize now. We'll once you finish with this.
So cement leak. Let me see. Yeah. Can you see it?
Yeah.
Right. So
quickly,
I've been
Prashant.
doing, yeah, quickly. So we're doing vertebroplastic ICO for over 12 years. And I have many leaks in the future, in the past, but never had a complication because of leaks. So this is a patient who was 50-year-old, presented with severe back pain, referred to me from oncology department. She had pain in the back, weakness in legs, 3/12. for 3 months, not able to walk for 3 weeks, and she has weight loss and loss of appetite. So this is MRI. You can see there's multiple marrow changes in the vertebra. You can make out against metastasis. And looking at the T1, T2 image, there's a lot of marrow changes.
You want to, just move on with what happened with the intra-op and the post-op quickly.
Yeah.
Wait, we have to wind up. Otherwise, the bandwidth we will lose. Yeah.
I know. I'll try to do it quickly. Don't worry about it. All right. So this was and you look at the L5, which is what is compressing the whole canal, and she had weakness in the legs. Though bowel bladder was normal, and this is the actual scan, which is a lot of tumor tissue, which is encroaching on the canal. So she had a PET scan, which shows a primary lung, and CT guided biopsy was done, which is metastatic adenocarcinoma. So she was referred to me for pain relief and neuro deficit. So I proposed to do this thing, but it's MIS fixation from L4 to S1 with decompression, MIS decompression using the tubes, and I did vertebroplasty at the high level and the bottom level. And so what happened? If you look at this level, which is I think T is probably L1 or T12. So what happened during vertebroplasty? I normally do vertebroplasty using the same instrument as kyphoplasty. So I use osteointroducer, and I try to fill the cement using the bone filler device. So particularly in this case, this was the end of the procedure, and I saw that the cement leaking into the canal. So unfortunately, I don't have the CM image, but the CM image is the same. And looked at it, and I was really alerted. And I told my registrar there's a leak, and that's a significant leak. Though, as I said previously, I'm doing it for last 12 years. We have leaks, even in epidural space, but small one, and never had deficit. So I alerted my anesthetist about it. I told him that there's a leak, and I will, because we do kypho and vertebroplasty under sedation and local anesthesia. I told him make it supine and wake her up as soon as possible. I want to see whether she can move the legs or not. If she moves the legs, then I'm not going to do anything. If doesn't, then I will decompress now. So patient was sun supine and was woken up. She moved the lower limb. I said, then we actually consulted among ourselves. I said, let's see what happened. And in the recovery, your power was 4 on 5, 4 plus 5, 5. Post-op, patient went to the ward, and she could walk after 3 hours. She went to the toilet, couldn't pass anything. 8 hours after procedure, could not open the bladder. She had some pain, but it was not that much. But unfortunately, I was not informed, and the sister on the ward consulted the junior doctor, and a Foley's in and out was done. 800 ml of urine came out, and so I was not informed yet. So next day morning, 8 o'clock, I rounded. I said, "Paul is okay, pain is gone," but my sister says me she has not passed urine yet. So I checked at the bladder, and the bladder was up to the umbilicus. And since she was actually on IV fluid the whole night, so she has about 1,000 ml of urine in the bladder. Did the Foley's came out?
She had a Cauda Icona presentation, is it?
Yeah. So catheter tug, I did the catheter tug. It was negative. Then I did a PR. To my worst fear, a PR where anal tone was not there. She couldn't fool my finger, and complete anesthesia. All right. Okay. So I immediately informed the OT. I went back to the X-ray, but the X-ray was done by the time. And then reviewed the X-ray. If you look at the X-ray, there was a huge amount of cement in the canal. Yeah. And same in the AP. So because I have, zoomed it, but if you look at the X-rays, it was not that much visible. Took in the OT, remove it, and the piece of bone was lying on the top of the epidural space, posteriorly. Normally, when you have leak anteriorly, but there it was posterior because my osteointroducer was in the midway between the pedicle. And when I tried to remove my the bone filler device, that cement was probably still liquid, and one of the pedicle has a breach. So the cement leaked from the osteointroducer into the pedicle, into the canal posteriorly. So this is the cement, and after surgery, this was. Post-op, still she was the same. I kept the catheter for 4 weeks. We did the routine interval urodynamic study, which shows that there was some strength is coming back in the bladder wall. refer to a urologist. The bladder sensor is better. This is now 3 months now, and she has some power came up. Still, I won't say that 100% bladder has been better. She can pass a stool, can sensation the stool. Her PR is better now. Her sensation, the perium has come back, but the bladder control has not come yet. So the take-home message from this is the whole thing is be very careful when you are doing a vertebroplasty, kyphoplasty. I've probably done more than 500, and this is the first case among the 500, but this can be the worst case. And whenever you have a cement leak, make sure you don't try only on the wake up test and strength. If it's in the because this was L1, so it was very near the corners. If the leak is in a corner and sizable, it's better decompress rather than wait for second day. Thank you.
Manish, Prashant, see, that is a good thing. See, when you have a symptomatic, especially where it is a symptomatic canal leak, and you have to decompress, because it's not only the compression, even the initial deficit happens because of the thermal injury. So because the heat it liberates. Polymerization cement itself will give rise to.
I understand.
That is one thing.
Leak, but you don't want to keep that cement into the deficit patient to be seen by your colleague.
Yeah, I fully agree with Prashant.
Yeah,
if there is any there is no sitting on a leak cement causing deficit.
Yeah. You can't defend your medical legally. Why didn't you decompress?
No, forget medical legally. For the benefit of the patient, if there's some reason causing deficit, you have to reverse it. Whether it
absolutely
may be controversial.
Manish, I don't know whether you guys got the point. I'm saying yes, we have to decompress. We cannot sit on it. What I'm saying is the thermal injury adds to the irreversible component.
Your point is second. We know that. Yeah.
And also with the cardiac, we know, Prashant, the bladder will take time.
This is very strange.
The signs she is showing recovery, she will improve.
Yeah. It may take some time.
I think we'll have to wind up. That was a fantastic. I think we had a selection of cases.
I think there's one small case of sacroplasty. If you allow, I just present it. Sacroplasty. It's 2 minutes.
Prashant, I think with this. Okay. The sacral insufficient fracture sarcopenia is also great concern. Patient coming with a lot of pain. A lot of time they spend in the bed or in the chair, and they come with a lower bottom pain. And sarcopenia is more of a cause of concern and a pain as well. Just quickly, Prashant.
All right. So this patient is a 60-year-old. I again referred from the oncology department. She is a survival of the cervical CA. Had undergo radiotherapy for cervical CA. She's remission. Came admitted this time with a lot of pelvic pain and back pain. Her VAS was like 8 to 9. I examined her. The X-ray was done. There was nothing visible. And examined her. Faber was positive. Ganselis was positive. And then squish test, which is when you press on the anterior superior spine, a lot of pain tenderness. So I got the MRI of the SI joints, and I saw this. There was insufficient fracture bilaterally, and if you look at the star image, there's the enhancement, marrow enhancement there, and same with another picture. So there's a bilateral sacral fracture. Her biochemical lab test was done, so vitamin D was low, PT was normal, and alkaline phosphorus normal. And then we spoke to the patient about treatment, and I gave her a treatment plan about maybe a sacral belt and maybe calcitonin and putting on teriparatide or something. But she was so much of one, she wanted immediate relief, so we decided to sacroplasty. So there are 2 types you can do it. The 2 ways, one is the axial and one is the longitudinal. So we prefer the axial one, where put the Jamshedi needle and bone osteo into the ala of the sacrum. Make sure that you do not you start lateral to the foramen, S1 foramen, and this was done. And we put about 1.5 ml of cement on both sides, or maybe 2 ml of cement on both sides. I'm very careful that the cement doesn't leak into the foramen. And this is the post-op. And look at this compared to the edema there and the X-rays. And the VAS has come down immediately 2/10. The discharge from the hospital, very happy. We put her on the anti-osteoporotic medicine. So this case is just to highlight that sacral insufficient fracture is something which you have to look for in the patient who have RT or chemotherapy, or elderly patient who had history of fall, trivial fall, and where you have all these tests, Faber, Ganselis, and the squish test is positive. So you make sure that you have an MRI scan because it's very difficult to see the fracture on the X-rays. CT scan sometimes is useful, but MRI is very, very sensitive. And there are many ways to build a cat, but one of the way I have done, probably I've done now 7 or 8 Cyclobugs in the last 4 years, and the results have been excellent. Thank you. Are you guys there? Murli?
Yes, sir. Yes, sir. We are there.
Yeah. Is Murli gone there? Or is it still?
Yes, sir. Yes, sir. Dr. Murli messaged me. There's a power cut at his place. So
I think let's wind up. Ms. Shreya, thank you very much on behalf of Torrent. Thank you, Dr. Rishi, Dr. Prashant. Unfortunately, Marcin could not join us today. Thank you, Dr. Rajesh. I don't know if he's with us. He presented fantastically. Dr. Hema has been with us all this while, and thank you very much. You answered the questions fantastically, and it was a beautiful presentation on osteoporosis management. With this, I think I would like, we should close this session. It's beyond 9:15 already.
Thank you. Thank you, Manish.
Thank you. Thank you.
Thank you.
Would just like to say thank you to all of you on behalf of entire Shellcal team. Big thank you, Dr. Murli and Dr. Manish for that lively session, and all the wonderful panelists for joining us, Dr. Rajesh, Dr. Hema, Dr. Prashant, Dr. Rishi, for being with us today. It was an active participation and live interaction on aging spine, and I'm sure it will be useful for enhancing all the attending doctors' practice. And we have planned continuing webinar series, and this Carve of Knowledge shall henceforth continue. And the video recording, a lot of participants have been asking for the video recording. So would like to share here that the video recording shall be available to you, and you all will get an email with the link from Shellcal Cares ID. And let us end today on a very positive note that we wish safety and health to you and your family. We salute you all for being the frontline warriors during these challenging times. Have a very good night, ladies and gentlemen, and a wonderful weekend. Once again, thank you all for joining us.
Murli is back.
Thank you.
Sorry, we lost the connection, man. Sorry.
Thank you, Murli. We had a great session.
Yeah.
Thanks. I hope everyone enjoyed and the week is benefited.
I just want to
Thank
know
you.
how many delegates joined in. I can't see more than 13 here. The entire session.
No, sir. You are at the speakers panel actually. So only you can see the speakers. So we had 450 people joining us today.
Oh wow!
453. Yes, sir.
And Shreya, till last minute, how many were there? I know probably a lot of people would have gone out and gone, but till the end.
So till the end, we had 316 people.
Very good. Thank you. So sorry, Manish, I think we thank you all, Shreya and the Torrent Pharma for supporting the academic work. And I think Manish must have summed it up. Manish, I hope you summed it up.
We did. Yeah, we did.
Okay. And